The one fly in the ointment with regards to this story of GLP-1 receptor agonists and cardiovascular disease is the fact that in the LEADER trial and the SUSTAIN-6 trial and the EXCEL trial and the top-line result from the dulaglutide trial that hasn't been published yet, it seems that there's evidence for benefit in patients with clinical cardiovascular disease, generally patients who've had a heart attack, a stroke, peripheral vascular disease that's been revascularized, or where there's greater than 50% lesions. So a broad swath of people with atherosclerotic cardiovascular disease, there's been benefit. But in those patients that didn't have clinical cardiovascular disease that were recruited in these studies, generally older patients with risk factors, we've not shown any hint of benefit with regards to cardiovascular outcome. Now, the standard story is it's because those populations were at lower risk, and so there were fewer events, and so we just didn't have the power to demonstrate the benefit. That said, it's been a consistent finding across 3 trials for sure, with the 4th one, if you read between the line in the press release, a suggestion that that's true as well. So it's a bit of a conundrum why we haven't shown any benefit in that setting. So the ADA ESD guidelines are quite clear. If patients have clinical cardiovascular disease using GLP-1 receptor agonists, and the same story is true for SGLT2 inhibitors, is a good idea to prevent cardiovascular events. But if people don't have clinical cardiovascular disease, there really isn't benefit that preventing cardiovascular disease or primary prevention is something for which we have proof of a role of the GLP-1 receptor agonists or SGLT2 inhibitors.
As I go forward and I'm looking at my patients with type 2 diabetes, it's again about individualizing therapy. If these patients don't have cardiovascular disease, or I think they're sort of a lower risk for cardiovascular disease, I don't have to think about that as I don't have to think about that when I'm making a decision about medical therapy. However, after diet and lifestyle, metformin is still the #1 recommended agent. The #1 next recommended agent, or the second class of agents, or if you can't tolerate metformin, which many people can't, is the GLP-1 receptor agonist, and behind that are the SGLT2 inhibitors. I think this is where the field is going. I think it's looking at how much efficacy do you need. We know the GLP-1 receptor agonist class is the most potent of all the classes out there. Is there cardiovascular disease? Is there chronic kidney disease? Is there heart failure? And that's what the ADA and the EASD have now said. You have to think about these individual factors. So for this woman, as I said before, not only does she need pretty potent glycemic lowering, she's had a cardiac event. If I can get her down to goal with a GLP-1 receptor agonist, and at the same time reduce her cardiovascular risk while doing so, then that is exactly what I'm going to pick for her. If, however, she had come in with kidney disease, or if she'd come in with heart failure, where the SGLT2 class might be a preferred agent, that's where I would be going. And there are 2 agents now preferred for cardiovascular risk reduction in the SGLT2 class.
What is our experience in using these agents in patients who have established cardiovascular disease? What I've seen most directly is that patients really appreciate the education and the potential for improving their long-term outcomes. When you talk to patients about what's important for them, sure, it's important for them to get to goal, for them to not have side effects that they don't like, but a lot of times patients want to see that they are doing what's best for them in the long run, and that they'll be there with high quality health span and a quality of living, so that they can be there for their kids and their grandkids, and et cetera, et cetera. But what patients like to see is that when we're giving them a new medication, that we're not just thinking about their short-term effect and what's in the number, but also what we're doing for their overall health. So with diabetes, and especially what we're seeing now with GLP-1 receptor agonists, is we're able to treat not just the glucose, not just the number, but think about the patient as a whole.